Thank you, everyone, for a great week. I have the last two talks and get to talk about one of my favorite things, and that really is about monitoring the patient. This first talk, we're going to discuss issues in the operating room, and then the second talk, think about outside of the operating room, with a focus on monitoring as we have done with current devices and really highlighting some new technology coming down the pipeline. So I think this is really one of my main take-home slides that I hope we come back to also in the second lecture. But really, what is our goal with physiologic monitoring? We have to deeply implant that before we start bringing a whole lot of technology in. How does that add to what we've been doing for a long time? How do we currently act on the data we currently have? And if we don't reconcile these things, then we're going to be deeply confused and maybe make decisions rashly and hurt someone. So in my thought, the goal of physiologic monitoring is to assess circulatory function, assess specific organ perfusion. We might use it to titrate our medication dosing, whether that be the anesthetic or vasoactives. We want good surveillance for physiologic abnormalities, right? I think so much of the theme of this conference has been, how do we identify the sick patient? And physiologic monitoring in its best role provides us that extra information, right? This patient is sick. I'm adding something to my clinical training, my clinical gestalt. This is helping me increase the probability with which I'm diagnosing this patient with something wrong, something I have to do, right? So we have a lot of other diagnostic tools in the armamentarium. So how did this physiology monitoring fit in? Really, that's what I want us to continue to think about as we talk about these different modalities. It's about diagnosis, treatment. Is my patient responding to that treatment? Because our operating rooms now, and this is my cardiac operating room, we have a lot of data. And this is really exciting to me for the next duration of my career from a research perspective, but to really hone in on these diagnostic questions. How do we take all of these numbers in, right? The numbers that we've been monitoring for a long time and incorporate new data. So there's a lot of important considerations that I think you can come back to anytime you're thinking about a monitoring device. Again, this applies to the standard modalities with which you use, but certainly needs to be a focus of anything new that we bring to the party. Okay, so frequency of measurement. How often are we measuring this data? You know, we now have the capacity to measure many things at 120 times a second, 240 times a second. I know you all are really smart, but that surpasses my brain's ability to assess, right? You almost need like a team of humans. You need a team of computers to really analyze things at that rate. So frequency matters. What about measurement error? Even in our classic blood pressure monitoring devices, right? Let's just think about a blood pressure cuff. How accurate is that really measuring the patient's blood pressure? I think we all know that there are some patients where we're like, I don't really know if this is a real number or not, right? It can be hard in some people. Does the cuff fit correctly? Where's the surgery happening? Do you even have an extremity to apply this in, right? So it's an important thing to think about with your current data, but certainly with these new devices. There's a cost to these, right? High cost to these new devices in particular. What do we do about charting the data? If we're going to make decisions off of it, we probably should put it in the chart. So my general approach before I sort of dive into these new devices is that they shouldn't replace what you're currently doing. And I don't think that there really is compelling data that would refute what I just said. There's nothing that should jump in and obviate what you're currently doing with these new monitoring practices. I do think you can consider them in the context of your current data and your current assessment. But right now, the standard is thinking about circulation, right? It is temperature, it is blood pressure, it is oxygen saturation, all of those things that perioperative care has really been built off of. So going to think about a case study, a sicker patient who's coming to your operating room, and how might these help. So new neurologic monitoring devices, one of the first main categories is depth of anesthesia monitoring, where really utilize EEG monitoring to extrapolate or assess the depth of anesthesia. And there are several different company devices that I list here. The next is cerebral oximetry, so near-infrared spectroscopy that literally, as I show here in this diagram, we send infrared light through the cranium and through the brain tissue to estimate the level of oxygen saturation. I study these in research as well, NIRS in particular. It's well known that even NIRS can give you a value for an inanimate object. It's been well published that melons, you can put NIRS on melon and give a number. Nonetheless, these have been in practice, particularly in cardiac surgery, for now over 10 years, and there is probably the most amount of data, I'd say, on cerebral oximetry. The trials have been very difficult to parse out because essentially we have sort of conflicting results. When we think about depth of anesthesia monitoring, I present here in your notes two trials that conflict in their results. One that showed a suggested decrease in delirium with the use of depth of anesthesia monitoring. The other that did not show a strong signal. Now, certainly with any trial, we can debate the intricacies of these trials, but again, it's where I started with, there's no slam dunk that these are yet exactly the prescription for you to dial in the amount of anesthesia for your particular patient. What about hemodynamic monitoring? There are some really exciting new technologies. The ClearSight system and the CNAP HD. This ClearSight system, as I show here with a picture, displays the finger cuff that this company provides, and essentially by providing some pressure to a finger and then looking at changes in pressure, not only estimates your blood pressure, sort of in a similar fashion that a non-invasive blood cuff does, but it actually can estimate at higher frequency. And so these claim to provide you more of a continuous blood pressure measurement. I'll say in practice that I find this to widely vary with the blood pressure cuff and also with an arterial line. So again, I come back to some of those tenets that I mentioned of measurement error and data that you get continuously that isn't confidently what you're looking at can be a problem. So I think you take it, if you use these, you take them with a grain of salt as this technology gets better, but you can very much understand how there are several patients that seem sick enough that, I don't necessarily want to put an arterial line in because it seems like a quick case. Maybe I can get by with his advanced monitoring system. It's highly appealing. So that's an option. And then with With invasive waveform analysis, there are several companies that have developed algorithms to analyze the arterial waveform pressure to estimate other physiological principles, cardiac output, volume status, these variables. And these are also promising, taking this data that we already have and perhaps giving us a little bit extra to get to diagnosis, right? To get to disease surveillance and perhaps even treatment. But those are not really here yet, I'd say. Overall, I think the goal is to incorporate these vital signs, maybe using computer algorithms to help our clinical decision support. I mentioned a couple minutes ago, right, about this is such an immensity of data that it surpasses the brain's ability to really analyze it, comprehend it, apply it, see the changes, do it again. So there really are some opportunities here for artificial intelligence, machine learning, to support a clinician. And one of those examples is the Edwards Hemisphere, where they have developed and marketed the hypotension prediction index. I don't know if any of y'all have heard that, but essentially this algorithm is delivered through a computer that connects to an arterial line, and the thought is that you can predict whether or not hypotension is going to occur in 10 minutes, which might be really helpful, because then if you can predict that, it suggests you're in a state of hemodynamic instability and you should do something to remediate that, to avoid becoming hypotensive. Interestingly, as compared to in this study I reference here, it unfortunately does not outperform the scenario where you just have a patient with a blood pressure between 65 and 75. So recent data suggests that this algorithm might not outperform just having a patient with a mean arterial blood pressure between 65 and 75. So it's a very disappointing result, but also a very simple one, right? Like it comes back to what I mentioned, how do we incorporate these new devices into what we already do? So we're also learning new standards for how these devices need to be compared. And clearly, a prediction index needs to surpass the ability of you just seeing your patient has a blood pressure of 68. If the goal is to predict hypotension. But really what we want to know is, coming back to what I said, is we want to know the patients that are in a vulnerable state. We want to diagnose them when we can treat that before it gets worse. There are other systems that look at coagulation monitoring. The ROTEM system is sort of well known for this, and there have been trials to see exactly what effect it might have in reducing blood product administration in different clinical scenarios. Down the line, there's also new approaches to kidney monitoring. Urinary biomarkers are in development to assess kidney injury during clinical care rather than wait 2 days to see AKI manifest itself. There's also continuous glucose monitoring. Y'all have seen the commercials of advertising actually just for all folks to check their continuous glucose. Well, it kind of makes sense. We might consider using those in the perioperative period for different reasons. And there's also other biomarker sensors. And what I think you'll see in the coming decade is devices or computers that try to integrate all of this data. And what my hope is in the development of those devices is that they deliver an analysis of your data within your context of understanding, right? I hope we don't reach a black box reality where it just says what it thinks is going on with your patient, because I wouldn't be comfortable with that. I would not be comfortable giving a medication to a person without really understanding how we arrived at that conclusion.